So I'm going to start recording, and I want to welcome you all to the August Wellness Nurse webinar. We're going to talk about medication reconciliation. This topic has come up for two reasons. One, it came up multiple times when I was talking to the nurses when I did the interviews with everybody back in June. And then with the launch of the new data system, PHL, it's definitely evident that folks are just wanting to walk through the process again. And we are also working on making this process a SASH protocol. So it's not a stamped, sealed protocol yet by the administrative team. They've all seen this. They're in agreement. We just need to go through the formality of making it the protocol that you'll see, and then going from there. So we're going to talk about a few things. Why perform a medication reconciliation? What is our SASH process? There's a bunch of tools that are quite helpful. We'll talk a little bit about documentation in PHL. They should have gone through more, they meaning the training team should have gone through a little bit more information during training. And if you have questions from here forward, definitely give me a shout and we can get online and look at the system or just talk it through. And when to perform the medication reconciliation, again, I talk about it 2 times, and then further training, and then if you have any questions, of course, we can go through those. So the objectives, there's 3. At the end of this training, you will be able to verbalize a rationale for performing a medication reconciliation, be able to verbalize and demonstrate medication reconciliation as part of the SASH assessment, verbalize the specific participant situations and criteria of when to perform a medication reconciliation. So with that being said, let's jump right in. This is the definition of medication reconciliation, and this is from the Institute for Healthcare Improvement Joint Commission. The Joint Commission for Accreditation of Hospitals has, they have adopted a very similar definition, slightly different, but very similar. Same components are there. Medication reconciliation is the process of creating the most accurate list possible of all medications a patient is taking, including drug name, dosage, frequency, and route, and comparing that list against the physician's admission, transfer, and/or discharge orders with the goal of providing correct medications to the patient at all transition points within the hospital. This has become a patient safety initiative nationally, and we're going to talk about how we can support that initiative, which is, they really, as you can tell, they talk about it from a hospital-based perspective. How does this relate to our work in the SASH program? We want to help our participants create the most accurate list possible of their medications, and compare that list with the medications from the primary care provider and discharge summary, either or, whichever you have available. The goal ultimately is to empower the participant family member to maintain their own accurate list of medications and share that information with our team as changes are made, so that we can help and support preventing adverse drug events and support safe and high quality care of our participants, especially as they enter and leave the medical system, the inpatient system. Why perform a medication reconciliation? Well, medication reconciliation, this is the process to decrease medication errors and patient harm. And the 4 bullet points here are very, again, hospital-based. So the first one is talking about obtaining a good list of medications when a person is admitted to the hospital or even seen in an outpatient setting. The second bullet point is looking at somebody's list of medications pre-admission, and then evaluating that list when ordering medications during the hospital stay and encounter, and then continuing meds home as appropriate. So, for example, you may have somebody that's, when they're in the hospital, they're on a different type of medication for maybe GERD than what they typically take at home. So that needs to be reconciled as the person is just discharged out of the facility. And sometimes that happens, and I think we've caught instances where it hasn't been caught, where we've had to make a clarification with the primary care or the patient has had to. Where we come into play is the third bullet, verifying the patient's home medication list and discussing unintended discrepancies with the physician for resolution. And either we can do that or the participant can do that. That depends on how involved the participant is in managing that. And providing an updated medication list and communicating the importance of this, managing this type of information with the patient. As we do, we try to teach folks to self-manage as much as possible. And these 4 bullet points came from the Agency for Healthcare Research and Quality. You can look them up. They've got a really nice toolkit. Again, it is hospital-based, but it really talks about transitions of care and reconciling medications. And when they say transitions of care, they mean coming into the hospital, they mean transferring within one level of care, like from an intensive care unit to the floor, from going from the hospital to a rehab unit, and then rehab unit to home. So there should be multiple reconciliations along that path. This is the 4-step process that hospitals go through, and I'm going to show you in just a minute how we match very similarly to this process. But the first step is to obtain a best possible medication history. There's also another, I'll go through it at the end, but there is an online training from the Quality Innovation Network of New England that is free. You can go through it. It takes about 45 minutes. You have to do it all at one time. You can't like do half of it and then come back to it. So I'll remind you of that at the end. But they talk about how to obtain the best possible medication history. That is kind of the crux of everything. If you get the best possible medication history correct from the beginning, then the next steps, they fall into line. But if you don't have that good information up front, verifying and clarifying information, just it does not go as smoothly as it could unless you've done that basic level of groundwork. So step 2, confirm the accuracy of the history. Step 3, reconcile your best possible medication history with prescribed medications, resolve any discrepancies, and then make sure you're closing the loop and supplying accurate medicine information. This is from World Health Organization. As you can tell from the organizations I've referenced, this is a pretty significant process nationally within the healthcare system. So let's talk about SASH and the SASH process. So we are looking for discrepancies, and we want to educate our SASH participants on the importance of the home medication list. And here is a very detailed flow chart. This is the flow chart that will become a protocol, and we're going to go through it step by step. Any questions thus far until I get into the SASH process? All right, no questions. I'm going to keep on going. So let's look at the beginning of the process. This is key, medication reconciliation. It is performed by the SASH wellness nurse. It is not performed by the coordinator, it is performed by the nurse because you need to have the medical understanding behind what it is that you are assessing. Very important. This is more than just listing a list of medications. It is a process of looking at medications, evaluating them, and then reconciling against what the participant should be taking according to the primary care physician. We will perform this step when we have a new SASH participant. We will then do this process annually during annual reassessment, and then transitions home from the hospital. And then I do talk about a pre-admission evaluation as well. But in accordance with your professional judgment as nurses, you may, I had a good example during one of the interviews where one of the SASH wellness nurses has a very busy blood pressure clinic. A participant came in. The participant didn't look right to her. Blood pressure was not their normal parameters, And she said, let's go home after this and look at your medications. And she did a new reconciliation, and come to find out there was an error on the participant's part on how they were taking one of their blood pressure medications. So that was her professional judgment, and she definitely went through and did a full reconciliation of the medications at that time. So in preparation of performing a med reconciliation, have the SASH participant prepare the following. One, they used to call this a brown bag. Put all your medicines in a brown bag, and we'd say bring it to the doctor's office, but we're going to be in the home ideally, and have them pull out all their medication prescription bottles, their over-the-counter medicines, their any herbals, vitamins, inhalers, nebulizers, injectables, eye drops, creams, and ointments. And have them available so that you can evaluate them and log them in PHL now. 2, have a recent medication list from the primary care provider or the hospital discharge summary. And there's 2 tools that you can use for this. One is there's a SASH information sheet for new assessments, and I'll show you that in a little bit. Or you could use an appointment reminder sheet. It's something that I just created in Word, and you can request whatever information you want, and medications, and the PCP med list is part of that. And if that participant is having a tough time getting that type of list, work with your SASH coordinator. This is the perfect opportunity for when you all meet during your weekly get-togethers to say, listen, I've got these 2 folks. They're scheduled for an assessment, a reassessment. I need your help in getting the medication list. Can you help the participant, or call the doctor's office yourself, because sometimes those lists might need to be faxed over. Ideally, we perform the medication reconciliation in the home. That is the best situation. However, we do know that some participants won't let us in their homes, and so make sure you have a private space to do this interview and the medication reconciliation as well. So hopefully you have maybe an office space or another room at the housing site that you can camp out in and perform the medication reconciliation and the assessment. So as you go through and look at especially the prescriptions, you're going to look at drug name, strengths, dosage form, the dose, the route, the frequency. Duration, that speaks to something like an antibiotic. If somebody is taking an antibiotic for 7 to 10 days, or sometimes low molecular weight heparin is ordered postoperatively for a certain period of time. What the last dose taken is, that's a question that you can ask. It will help you understand if they are taking their medications, and the last fill date. Look at the last fill date on the bottles. I did have a participant who thought that she was taking her verapamil every day. Her heart rate was well over 100 when I did her assessment, and in looking at her verapamil bottle, the medication hadn't been filled for a good 4 months, so clearly she wasn't taking it every day, but she thought that she was, and obviously there was a memory issue going on there. Compare the list that you develop from all of these medications from to the primary care list or the discharge summary, and if you cannot get a list for the visits that you're meeting with the participant, get it afterwards, and then do the cross-check after the visit. So were any discrepancies noted? If no, great. We love those situations. You can just finalize your documentation in PHL. If yes, we want you to have a discussion with the participant and let them know there's some discrepancies here. Dr. Jones says you should be taking Lasix 40 milligrams, but in reality what I see is you're taking Lasix 20 milligrams, and how do we reconcile that? And sometimes the participants might say, listen, I've got this, I'm going to make the phone call myself, don't worry about it, I'll take care of it. And then there are definitely other situations where participants will want our support and will be completely fine with us calling and clarifying. Once you've clarified the discrepancy or the participant has closed the loop, do you close the loop with the participant or have the participant close the loop with you? And of course you're obtaining accurate information from the primary care doctor and then finalizing again your documentation in PHL. And then during this process, always stress the importance of the home medication list to the participants. So they carry it on their person. They can give it to their primary care provider. They update the list when there's changes, let us know when there's changes, and carry it for just in case of emergency. Any questions about the process? All right, I'm going to keep going then. Some additional tools for you. I talked about some tools all throughout here. This is one tool that is available to you right now. It is on the SASH website under Tools and Resources. It's the Medication Management Checklist. I just pasted the very beginning of that in here. And this is a great tool that talks about, first of all, reviewing the medications as we just went through, but also then evaluating the medication management, how somebody is managing their medicines. So I encourage you to use that. This is a tool that was developed by a couple of SASH wellness nurses probably about 2, maybe 3 years ago now. It works well, especially if you have somebody that is probably a large medication profile and you want to really evaluate their meds. It's definitely a good tool to use. The other 2 tools are the SASH, the information checklist for a SASH assessment. This shouldn't be too new. This is a very old form. I remember it from the beginning days of rolling out panels. But it does remind folks of things to bring for their SASH assessment, all their medications, and then any doctor's reports from the hospital or report from a doctor's appointment. And then this is the appointment reminder that I was talking about. I'm showing this to you for 2 reasons. One, it does outline the information that you want your participant to bring to their appointment with you or have available if you meet them in the home. And you can edit this. This is a Word document. You can add things, make it your own, that sort of thing. But for those folks that were difficult to schedule for a SASH assessment, I would go ahead and schedule them. I would schedule them out a few weeks and put them on my calendar and send them this note. And that pretty much got their attention. So if you're having trouble scheduling somebody, I would go ahead and schedule them and give them the information, and then I put on here the name and phone number of my SASH coordinator if that date and time didn't work for them. And sometimes it worked just fine. They were completely fine with that appointment time, and then that would also get their attention to say, oh, you know what, I'm not going to be home that day. Can we do a different day? But it got their attention anyway. So I encourage you to try that. It works best with your participants that are in a housing site. I did try using it with folks that were in the community, and it really stinks when you do make the trip out into the community and nobody's there. So definitely worthwhile for the housing site folks. Now, these tools are from that Quality Innovation Network that I discussed. And this is part of the online training. This is a medication reconciliation checklist. The Quality Innovation Network suggests having 2 sources available to go through and create the best possible medication history. And those 2, we have those 2 available usually. And one is the medication bottles themselves. And then the second one is the primary care office after visit summary or the discharge summary as well. So one of those 2 we typically have, and like I said, if you don't have that list at the time of visit, get it after, and then I would say within 1 to 2 weeks, make sure you're doing that reconciliation process because it may take you another week until you're back on site and you have the list in hand. And again, your SASH coordinators can help you in obtaining that list. You are not on site 5 days a week, but your coordinators are much more available than you are. That's a delegable task, asking them to obtain that medication checklist. The nice thing about this reconciliation checklist is it is very detailed. You will see, the first step is use proper hand hygiene while entering the patient's room or surroundings. So it reminds you, wash your hands, use your hand sanitizer, and then, if somebody's in visiting your participant, maybe they're there for the visit, or maybe it's just a friend, and you need to ask them, is it's still a good time for you guys to meet? Do they want that person present or not? And resolve that situation. And so it goes through all of the steps. There are a few things that I really like here. Ask specifically about vitamins or over-the-counter medication using examples. I'm going to show you this next. There's a probing question handout, which is really good. And then use open-ended questions for descriptive answers like current medications, when and how many times a day, and for how long has the medication been used. You will remember on PHL, I think there's a start date for meds, and so if you have that information, great. If you don't, it's not a mandatory field. Always thank people for their time and then reconcile the record with other sources of information. So that's a nice checklist, good reminder. And then this is the probing questions, and I really do like this. Do you take any medications for headache or pain? Do you take any medications for your nose or sinuses? So this is a really good way to ask the open-ended question that will prompt, oh yeah, I do take something for sinus. I don't take it all that often, but I take Claritin during pollen season, that sort of thing. So definitely helpful, and these tools will be available for you. As we educate our participants on maintaining their own list of medications, one of the common tools that people can use is the File of Life. And it is totally coincidental that I was able to download a PDF that is the Connecticut File of Life. I could not find a Vermont one, but I know that there is one that the emergency crews have supplied us in the past. So there's various forms out there in terms of the File of Life. There's also the Vial of Life, where that is kept in the freezer in actually a little plastic vial. But this has got a lot of information on it. Obviously, there's a short section for you to put your medications on. But this is a good tool for your participants to get into the habit of keeping available in their apartment. And then they have their medication list, and then we could make a copy of this. They could even keep a copy in their wallet if they wanted to. Let's just chat quickly about PHL documentation. So as you gather this information, you will add each medication into PHL, and you'll enter in the medication name. These are just screenshots, obviously. The strength, the units, the dosage frequency, dosage number, method. Method is it oral? Is it injection? Is it whatever it is? And then any special instructions. I want you to keep in mind that these drop-down lists here, right now, as you probably heard during PHL training, we're not using a subscription service for a medication library. That is coming. Right now, Stephanie and the team have downloaded the medications that were utilized in DocSite. So those are all available. So the medication list, it's probably outdated, and so what Stephanie has asked everybody to do is just start creating a list of medications that are not available. So you can do that. She's also trying to find out a date from PHL as to when will they have the subscription service up and running to understand how long do we have to work with that. The second part of the documentation is looking at medication compliance. Is the client taking their medication? Are they refusing to take their medication? Are they not taking it because of side effects? If they are taking as prescribed, that option is all the way over here. And then medication compliance status at the system level. Do any of these issues occur for the patient, or you can click NA. And Jody says, love this screen, very handy. And so these, keep in mind too, these two boxes here, those we can manipulate some as well. Prescribing provider, if you have that information, and this is where I was talking about the prescribed on date. If you have that information, great. If not, it is not a mandatory field. And then dispensing pharmacy information as well. Right now, you may have a participant that gets all of their medications filled by one pharmacy, which is great. And then we know that we do have some different pharmacies for different meds. Like somebody might be using a mail order for certain meds and then the regular pharmacy for others. And then where was the information gathered and any notes. So that's PHL, and I just wanted to bring up this little screen here just so you could see it a little closer in terms of the compliance issues. We are evaluating the Meriski scale, which I think many of you may have heard about the Meriski scale. We looked at it about a year ago. Meriski is a subscription service as well, so we would need to find funding in order to implement that type of software, and that's something that I've been tasked to evaluate. Any questions so far? We've talked about the SASH process. We've talked about the rationale as to why we're doing this. We've talked about some tools, and we've talked about PHL documentation. Any questions that anybody has other than loving the screen? Any concerns about going through this process? For those of you that were on DocSite before, this should seem familiar. It should feel similar. It is, again, I think trying to incorporate a software system in your interactions is going to take, it's going to take practice again. You have to get used to that process again. When are we performing the medication reconciliations? As I said, new assessment, SASH reassessment, and transitions of care, specifically transition home. However, on pre-admission, if you go through a reconciliation with your participant and make sure that their home medication list is accurate, it really helps out when they go in for their admission. It's refreshing the information so they're able to be a strong advocate for themselves and they have it written down. Discharge home, obviously medications from discharge may be different than the baseline medication profile. And you may catch things. We've had instances, and one I can recall specifically where one of our nurses was reconciling medications from a discharge to home and could not find the diabetes medication that the participant was taking. What happened was the participant, when asked if they were taking the diabetes medication, was asked about the generic, and she said, I don't take that medicine, and it got dropped from their medication profile. So the SASH wellness nurse caught this, bless her heart, and did a had to go back to the primary care and have that discussion with primary care, get the medication restarted, and then a few other interventions after that as well. So that was very, very helpful. And Jody asked, would you say a transition discharge from home health is considered a discharge? It is a transition, so yes. And Todd says, I was adding meds to PHL yesterday. Is it okay that ciprofloxacin is listed as Cipro? I would say no, but let's keep track of that. That would be one of the medications that we should get clarified. It should say ciprofloxacin. Basically, we're being asked to reconcile after a discharge from off home health. Yes, we are. Anytime that they get discharged off of home health, there should be a warm handoff there, and hopefully with patient paying now, you're getting notified when somebody is being discharged from home health as well. Changes in the medication profile from the PCP and specialist, and when the SASH participant notifies you of a medication change, hopefully those go hand in hand. When they come back from a doctor's office, they'll say, hey, Dr. So-and-so changed my carvedilol, and it was 3.25 or 3.125, and now it's 6.25. And so you'll go through and do a reconciliation of that medication as well. And in accordance with your professional judgment, anytime that you feel that something is not going well with your participant, you want to look at their meds again, by all means, that is an opportunity for you to get in and look at them. Some of the barriers to a medication reconciliation, and these are systemic-wide. There is, historically, there hasn't been a clear owner of who has this task within the healthcare system, and now we're seeing healthcare systems implement medication reconciliation staff, be they pharmacy, nursing, and such. Interprofessional collaboration, as I'm sure you've felt time and time again, sometimes that can be difficult in getting phone calls back and trying to figure out what dose, what kind of med somebody is taking. I had somebody talk to me yesterday about a person who has high blood pressure. Blood pressure is controlled. The participant says, I am taking a blood pressure medication. The nurse says, no, you're not. I don't see anything here. None of these meds are for blood pressure management, and so she also pulled up the med list off of PRISM. Still no blood pressure medication there, so she's now trying to figure out from the primary care what the story is there. There's not a standardized process, so we're trying to standardize as best we can. Sometimes our patients aren't able to provide the information, and it's sometimes tough to link that best possible medication history with each transition of care, and it also is timely, as we know. So some folks will say, well, how long would it take me to do this? It's hard to say. If you have somebody with, say, 3, 4, 5 medications, it may take you 15 minutes to do a medication reconciliation. Those folks that have 15 or 20 medications, that's going to take you longer. And how readily available do you have all of your information? That's why the upfront prep would be key. Some of the other barriers during our SASH visits are the mental health issues, paranoia, patients who are like, I'm not going to tell you my medications. I don't want to discuss that with you. The poor historian who has memory issues, and as I said, mental health. Disorganization. When you go into somebody's home and there's medications everywhere, they're in the kitchen, they're in the bathroom, they're at the kitchen table, they're in the cupboard, they're at the chair in the living room. Pills that are without medication bottles, and that's always a challenge as well, trying to figure out, somebody says, oh, this is what I take, and it's just pills, they don't have the prescription bottles with them, and lack of a medication list or from the primary care or a discharge summary. So one of the other tools I want to share with you today is a free app. It is for, you can put it on your iPhone if you have one, or an iPad. It's Medscape. It's free. This is a picture of it upon entering the application. They've really come a long way with this app. I still can't believe it's free, but you can look up various medications. You can look up diseases. It also has a pill identifier, which is pretty handy. It talks about, what size is the pill, what shape is it, what color is it, and it works you into figuring out what that pill is. Then there's also a drug interaction checker. So if somebody's having a problem and it's something new and you're thinking maybe it's the medications, you can definitely start here and do a little research on your own. And you can also pull in the pharmacy, and I'm going to talk about that in just a minute. There's a recommended training for everybody to go through. This is an excellent resource. It's really detailed on this medication reconciliation process, and it is coming from the facility hospital-based perspective, so you have to keep that in mind. They do discuss using pharmacy in this process, and we can include pharmacy if you deem it appropriate. So if you want to include the pharmacy, because I've done this a couple times, somebody that's had a really complex medication profile, or if I thought that there were drug-drug interactions occurring, or maybe it was such a complex profile, I was looking for any suggestions on how to make it easier. that's when I pulled in the pharmacist. You've got to add the pharmacy to the SASH participant use and disclosure. You have to have your participant initial and date that addition. And of course, you're going to let them know. Say, I'd like to really pull your pharmacy into this. Are you okay if we do that, and see what information they could offer? So you can absolutely pull them in. This is a link to the training, and that will be available to you after we get everything posted to the SASH forum. So next steps, there we go. So the flow chart that I showed you will be officially reviewed by SASH administrative team. I encourage you to take a look at it. If you have any suggestions, definitely let me know within the next few weeks. I don't think we'll have it fully approved until, I want to say September, early September. And then once it's an approved protocol, that information will be distributed to you. And then the last thing I want to tell you is I'd like you to save the date for our next SASH Wellness Nurse webinar. That will be Friday, September 15th at 8:30 a.m. September will only be offered on one day. We have a special guest, Dr. Sandra Steingard. She's the medical director of Howard Center in Burlington, and she's going to talk to us about schizophrenia and psychosis, the medical and non-medical treatments. And she and her team are piloting some new interventions, and she thought that the Wellness Nurse team would really be interested in hearing about those. So I'm really excited, really happy that she agreed to speak with us, and so she will be on our next phone call. So save the date if you can do that now, and then Kirsten will send out Kirsten or I will send out the official invite. Any questions anybody has? If nobody has any questions, I'm going to give you guys back about almost 20 minutes in your day. If you have any questions, and yes, Jody, you can definitely call my cell to talk about something, and thanks, Todd. Thank you very much. You guys have a great day. TGIF, I am on vacation next week. I will be back Monday the 21st. So take care, everybody. Bye.
Bye-bye.
Bye.